Good afternoon, and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Today, we'll be discussing colonized versus active MDROs, or multi-drug resistant organisms. Today's discussion will be a rebroadcast of our March 15th presentation by Quality Insights Medical Director Dr. Jean Storm, and following the presentation, we'll have a live Q&A with Dr. Storm. Everyone has entered the meeting on mute, but if you have questions or comments for our discussion, please submit them using either the chat or the Q&A tool in your Zoom menu. We encourage you to join us every Wednesday at 2 p.m. for more of our weekly webinars. Next week, we'll be joined by a guest from West Virginia Project First Line to talk about the state and national programs, free resources for information, to talk about the state and national programs, free resources for infection prevention. We will also have a special webinar 2 weeks from today on Wednesday, April 12th. Dr. Storm will be giving a 60-minute presentation on adverse drug events. This webinar will be eligible for continuing education credits for nursing, and I will drop a link in the chat shortly where you can find more details and how to register. And now I'm going to share my screen and start playing the recording of our presentation from March 15th. And when it's done, I will stop the video and we will have our Q&A. And the video will begin with our introduction of Dr. Storm. This will take just a moment to set up. Okay, you should be seeing my screen, and I will hit play here in a moment, and you should be able to hear the audio coming through my computer. Please comment in the chat if you are having trouble hearing. To introduce our guest, Dr. Jean Storm. Dr. Storm is Medical Director here at Quality Insights. She has a background in nursing home care, internal medicine, and healthcare leadership. Most recently, she served as Associate Medical Director for Optum United Healthcare. She has also served as Regional Medical Director for 38 long-term care facilities in West Virginia. She earned her DO from Lake Erie College of Osteopathic Medicine and completed her postgraduate degree training at Mill Creek Community Hospital in Erie, Pennsylvania. Dr. Storm, thank you for joining us again.
Thanks, Kathy. So today we're going to be talking about the difficult topic of multi-drug resistant organisms. And I said in the title that it's a slippery slope. And I have found in my clinical practice that it is definitively difficult to figure out when we need to treat. And we know that treatment is not benign. I was talking to a physician the other day, and I was discussing about antibiotic use, and this is a surgeon, and he said, well, we would just treat that with antibiotics. And I said, well, that's really not what we're supposed to do as physicians. So, it's something that I think physicians don't often think about the impact that we have when we start antibiotics. So we really have to be careful and have a good framework to know when we're going to be initiating antibiotics and for what. So I wanted to start talking about Ignaz Semmelweis, and he was a obstetrician, and he was an early pioneer of antiseptic procedures. So Dr. Semmelweis would deliver babies in a hospital where there were 2 units. And in one of the units, nurses at that time would be delivering the babies. And then there was another unit where physicians would be delivering the babies. What he recognized was that in one of those units, there was a very high rate of sepsis following mothers delivering their babies. So he did a quality improvement project and gathered some data, and he realized that the unit that had the high incidence of fevers following childbirth was the unit where the physicians were delivering the babies. And what he discovered was that the physicians were doing autopsies between delivering babies. So they were bringing the bacteria from the from the autopsy specimens, and they were not washing their hands in between delivering babies. So he pioneered antiseptic technique, and he proposed the practice of washing hands with a chlorine solution to prevent the spread of infection in postpartum mothers. Needless to say, he was profoundly ridiculed, and he actually ended up going crazy because he tried to push this issue so much that he ended up in a mental institution, and he actually ended up dying there, unfortunately. So what is an MDRO? It's a multi-drug resistant organism that's typically a bacteria, and these bacteria are resistant to one or more classes of antibiotics. They are frequently resistant to the most common classes of antibiotics. We're talking about penicillins, the very basic antibiotics that we would go to for our infections. MDRO infections, we know, are associated with longer hospital stays, increased costs, a higher incidence of people dying. These are infections that are very difficult to treat because we have fewer antibiotics available. I don't know if you've ever seen a urine culture with a multi-drug resistant organism, and it is very challenging, especially if the patient has antibiotic allergies, if they have compromised renal function. So you are exceedingly limited in the antibiotics you can choose based on what the organism is resistant to, what the patient is allergic to, and that some drugs that you can't give because of their renal function or other factors. So MDROs are becoming more prevalent, and they've increased dramatically, especially in nursing homes. MDROs have definitively increased, and I would argue that the nursing home setting is caused the increase in MDRO infections. So what are examples? MRSA, we all know. MRSA's been around for a long time. In preparing this, I saw that it was first discovered in 1968, so MRSA's been with us for a long time. VRE, vancomycin-resistant enterococci, ESBL, which is our extended spectrum beta-lactamase producing gram-negative bacteria, and CRE, carbapenem-resistant enterobacteriaceae. There's others coming all the time, emerging as we speak. This is just what bacteria do. They want to be able to be resistant to antibiotics in order to survive. So common sites, respiratory tract, heart valves. We've all seen MRSA, endocarditis, skin and soft tissues. I'm sure you've seen MRSA infections in the skin, osteomyelitis, so infection in the bones, gastrointestinal tract. Urinary tract is a big one. I'm sure we've all seen MDRO infections in the urinary tract and other locations. So we're going to talk about colonization versus infection. And I think that this is a really important point. And I believe in making things very simple. I think simple is the way to go. So when we look at colonization, colonization means that a potential bacterial pathogen is present on or in the individual's body. This might be an MDRO bacteria. It might not be an MDRO bacteria. So individuals, people who work in healthcare, patients who've been in the hospital might be colonized with MRSA. This does not mean that they have an active infection, and this doesn't mean that they necessarily need treatment with antibiotics. It does increase the risk for infection. So if a patient is colonized with a bacteria, an MDRO bacteria, they are going to be at risk for infection with the bacteria. And we're going to talk today about how we recognize infection so we know when to initiate antibiotics. So that's the most important thing to recognize. When an infection is present, so we know when to initiate antibiotics. So individuals who are chronically ill, immunosuppressed, who have been admitted to the ICU, these are a lot of our nursing home patients. These patients are at increased risk to get an infection from a colonized MDRO or other bacteria. So we have to keep this in mind. Endogenous versus exogenous. We don't need to just worry about infection that's present on a patient's body. That's endogenous. So that's when an individual develops an infection from a bacteria that they are colonized with, that's on their own body. Exogenous means the patient develops an infection from a source outside their own. So it could come from a surface, or it could come from another individual who is colonized with a bacteria. This is why it's really important for us to realize that the whole nursing home is a unit. It's not just one patient isolated. Each patient, every patient, we're going to have a whole, they're going to affect each other. So that's why we have to keep that in mind. I found this study very, very interesting about MRSA. So this study was done, it was a survey about nursing staff perceptions of MRSA, and they polled nurses and nursing assistants. And the first question was, antimicrobial resistance is a national problem. And you'd think, yes, most nurses would agree, most nursing assistants would agree. So most nurses agreed that it's a problem, it's a national problem, but that was a little bit lower for nursing assistants. When you ask these same individuals if antimicrobial resistance is a problem at their own facility, those rates dropped, right? So they say, this is really typical just of human behavioral in general. It is a national problem, but it's not a problem here, right? But we know that's not true. We know that MDROs are a problem nationwide in every facility, hospitals, nursing homes, every healthcare environment. So this is just what it demonstrated. And most nurses and nurse assistants didn't feel that they were at risk for getting MRSA, but they did feel that their patients were at risk for getting MRSA. So super interesting study. I think this just needs to draw attention that, ourselves and our staff, that we all need to be aware that it's not just outside, it's not, somewhere else, that it's in our own facilities. So when we talk about MDROs, we're walking a fine line because it's important to recognize infections early, because we want to, in our nursing home residents, we want to recognize these MDR infections early because they're so severe. So we want to prevent lengthy hospital stays. We even want to prevent hospital stays altogether. And we want to prevent death because MDRO infections are serious in our patient population. But we really need to be judicious with our antibiotic prescribing, because the more antibiotics we use, the more resistance that we create in bacteria. So the more bacteria we use, the more MDROs we're creating. So we have to be really careful and thoughtful about when we initiate antibiotics. A study done in 2020 illustrated that almost half of all residents are colonized with an MDRO. So this is really good information to keep in mind when we get culture results and the individual does not have symptoms or signs of infection, because then we know that 50% of our residents are colonized. So this was a study that was done. The top portion, this number one, was the number of residents who had previously known MDRO colonization status before the study was done. The researchers went in and swabbed every resident in the facility, and you can see the bottom portion was what they discovered. They discovered a lot more patients were colonized than they thought. When I look at this, it gives me 2 points to think about and bring into clinical practice. Number one, we know that almost half of our residents or facility are colonized with MDRO organisms. So therefore, if we get a culture result and the patient does not have symptoms of infection, they don't qualify in our criteria for treatment, we know that they are colonized. We say, a lot of over half of our patients are colonized with MDROs. It also tells us that we need to be vigorous with our infection control policies, because half of our residents are colonized with MDROs, and we do not want to spread. We don't want to put other patients at risk. So we need to be extremely vigilant with our infection control policy. So this is what this study tells me. So how do we know when to test if we suspect someone has an infection with an MDRO? So we know about half of our nursing home residents are colonized. We have to know when to test for an infection and which tests to order, because if we have a culture that's positive for an MDRO, it might or it might not indicate that the resident has an infection. So it's really a good idea to determine first that we suspect definitively that this resident has an infection prior to obtaining a culture result. So then we don't have a culture result that's positive and we're not sure what to do with it. Because once we have a result, we have to address it. Once we have a test result, chances are we have to address it. We might have a family member saying, my mother had Pseudomonas in her urine. What are you doing about it? So it's really important to think about what you're going to order prior to having that test, because once you have the test result back, you can't go back in time and not have that test result. There should be a clear indication that symptoms are most likely caused by an infection prior to initiating treatment. I wanted to illustrate this with a case that I dealt with recently. So an 88-year-old resident, advanced dementia, had one emesis, one episode of vomiting, and then she had one episode of diarrhea. She was lethargic immediately following the episodes, and the facility was really great and started IV fluids with normal saline. Vital signs were all stable. So this was a resident that could not give us history, couldn't tell us what her symptoms were because of her advanced dementia, but her vital signs are all normal. She's afebrile. The attending physician was called about what happened and immediately ordered CBC, a CMP, UACNS, blood cultures ×2, a D-dimer, an EKG, and a chest x-ray. So a pretty extensive workup for some lethargy with emesis and diarrhea. The resident was at her baseline 4 hours after the episodes of vomiting and diarrhea. So in this case, I'm not so sure that all of those tests needed to be ordered, especially the D-dimer, considering, I know we're talking about MDROs, but a D-dimer is typically going to tell us if the patient potentially had a PE, she was on room air, oxygen saturation was fine. So, in this case, we potentially might have to deal with a urine culture that really doesn't fulfill criteria for infection. And then we have to determine if we're going to give her antibiotics that she really doesn't need because she doesn't qualify for an infection according to criteria that we're going to talk about. So appropriate antibiotic use. All residents in nursing homes with high rates of antibiotic use are exposed to 24% greater risk of antibiotic-related adverse events. These are all residents in the nursing home. So when you're giving patients antibiotics in the nursing home, you're affecting all residents in the nursing home. Adverse events include C. diff, or antibiotic-resistant organisms. So it's something to think about. If you give antibiotics to one resident and they get C. diff, if they needed the antibiotics or not, you're putting all residents in the facility at risk for C. diff because you gave that one resident antibiotics. I thought this statistic was really interesting. Each day of antibiotic use in a nursing home is associated with 0.4% increased risk for antibiotic harm for each resident. So each day that you give antibiotics, each resident in that facility is bearing the burden of antibiotic-related harm. This is why we really have to be careful about antibiotic use, and we really have to be vigorous with our antibiotic stewardship. So when do we know it's an infection? I'm sure you've all heard of the McGear criteria, and this is more of a surveillance tool, and it tells us when an event can be defined as an infection. So this is not clinical criteria. This isn't how you decide to initiate antibiotics. We'll talk about what we use for when we want to initiate antibiotics, but this is not that. We have to have all symptoms must be new or acutely worse. Alternative non-infection causes of symptoms are considered prior to the event being determined to be an infection. We can't just say, throw it in the infection wastebasket and we're done. No, we have to make sure we consider non-infectious cause of symptoms. Like in our prior patient study, we have to think about, did she have a vasovagal episode? Is she having a stroke? Is she having an acute kidney injury? We have to think about non-infectious cause. An infection is not identified based on one piece of evidence. So if we have a positive urine culture with MRSA in it, that does not tell us that we have a urinary tract infection. We need to have the entire clinical picture fit a urinary tract infection before we make a diagnosis. So I don't know if any of you have heard of the Choosing Wisely campaign. It is an initiative of the American Board of Internal Medicine. I would highly encourage you to go to the website. It's really wonderful resource to kind of determine how we should be making decisions. And I pulled this up because this is the Society for Post-Acute and Long-Term Medicine. And one of their Choosing Wisely initiatives talks about asymptomatic bacteria. Asymptomatic bacteria is essentially bacteria present in a urine culture that is not causing an infection. Even greater than 100,000 colony forming units can be asymptomatic bacteria. And it's one of the major drivers of increased adverse drug events, overuse of antibiotics. So we have to make sure that clinical criteria is met. Went forward there. We have to make sure that clinical criteria is met prior to initiating antibiotics, and we'll be talking about which criteria we should use. So which criteria we can use. McGeer criteria, as I said, is used for surveillance purposes. It determines if an event should be counted as an infection. It's not a clinical tool. Our LEB criteria is what we should be using as a guide to determine when antibiotics should be initiated in every patient encounter that we think could be an infection. This errs on the side of treating likely infections because, as we said, in our resident population, they get sick fast with sepsis, especially with MDROs. So this criteria does err on the side of treating likely infection. So this is what we use to determine if antibiotics are appropriate in an event. I also wanted to pull up the Improving Outcomes of UTI Management, the IOU. So this criteria is based on the presence that most UTIs that we see in the long-term care setting are uncomplicated cystitis. They're not sepsis, they're not urosepsis. So this tool helps us differentiate if we have an uncomplicated UTI or we have asymptomatic bacteriuria, which is colonization and not an infection. So I'll show you that and you can pull that up in the slides. So this is your McGeer criteria. This is going to determine if this event that happened can be classified as an infection. This is not going to tell us if we initiate antibiotics. And you can kind of look through all of these criteria to determine if the event was an infection. The LEB criteria is what we should be utilizing to guide us with antibiotic treatment. So as you can see, residents without a urinary catheter, acute dysuria alone, or fever with one of the following symptoms. So if we have a patient who has dysuria, they have burning with urination, or if they have a fever, and then they have one of the following: urinary urgency, urinary frequency, suprapubic pain, gross hematuria, urinary incontinence, and we have a positive urine culture, we can go ahead and treat that as a urinary tract infection. And residents with a urinary catheter have to have at least one of those symptoms, and then we would go ahead and treat. So we're more sensitive to treat residents who have a urinary catheter with this criteria. The IOU algorithm is, you can just kind of follow along, and this is going to differentiate whether we are going to treat this as a possible urosepsis, if we're going to treat this as a simple cystitis, or as a asymptomatic bacteria. And I think this is really important, and you can document in your notes that what criteria you utilized, just to justify your actions. So these criteria are available for any kind of infection you suspect with an MDRO. This is for skin and soft tissue infections. As you can see, you initiate antibiotics if you have new or increasing purulent drainage from the wound, skin, or soft tissue, or at least two of the following symptoms: fever, redness, tenderness, warmth, swelling. So another great tool. These tools are found in the AHRQ. They have a huge antibiotic stewardship toolkit, and you can download all of these criteria. This is for respiratory infections. Again, you can kind of read through the criteria. So I would encourage you to post these in your facility so your providers know that we are utilizing these criteria for appropriate antibiotic prescribing. And I would say that they, you might treat individuals that you perhaps wouldn't. It just is going to guide you for appropriate antibiotic prescribing. So whenever I think about long-term care management, clinical management, I think about low-hanging fruit. Let's use checklists prior to obtaining urine or other cultures to determine if the culture is needed or if antibiotics are needed. Use checklists after culture is obtained to determine if the antibiotic is needed. More challenging than the first one, right? Because once we have a culture, it is exceedingly challenging to not want to treat that culture. Use checklists to communicate with families, medical powers of attorney who ask for cultures. I do this all the time in clinical practice. I think it's really important to let families know why you are doing what you are doing. And use checklists as a reminder that it is not standard of care to test for cure. We should not be getting chest x-rays to check to see if pneumonia is gone. We should not be getting repeat urine cultures to determine if our UTI is gone. I wanted to pull up choosing wisely again, because number 12 is don't order routine follow-up chest imaging for post-acute and long-term care residents with community-acquired pneumonia whose symptoms have resolved within 5 to 7 days. So we do not check a chest x-ray after antibiotics have finished. It's just going to muddy the water, and we're not going to repeat treatment unless the resident is showing signs of infection according to criteria which we just discussed. I wanted to just bring up the all-important SBAR, Situation Background Assessment Recommendation. That's what SBAR stands for. It's a tool. It guides the initial assessment. These should always be used in long-term care setting when you have a change in condition, when you want to communicate with the provider. It helps organize your thoughts in order to provide information to the provider. It helps you slow down and think through complex problems, which we need to do more of in the long-term care setting. It's not often necessary just to make a knee-jerk fast decision. It is really a good idea to slow down and think about why we're doing what we're doing, and the SBAR helps. This is a suspected UTI SBAR. You can utilize them for any type of infection you suspect. And then when you call your provider, you can say, I filled out the UTI SBAR, and this is what I'm finding. I think they would appreciate it. I wanted to talk a little bit about chronic trach patients because I know some of you have chronic vent units. So with trach patients, bacterial colonization is a big problem, and I'm sure you are all well aware of what happens when you have increased sputum in a patient who is a chronic trach, and what do you do with those sputum results if the patient is not showing signs of infection according to criteria. So this is a study that was done following 39 patients with chronic trachs. Almost all were colonized with pathogens at the stoma site or trachea, mostly with Staph aureus and Pseudomonas, and I'm guessing they're mostly MDROs. 18 of the 39 patients were treated for respiratory tract infections during the 12-month study period. So a good amount, almost half, were treated for respiratory tract infections with antibiotics during the year that they looked at these patients. When the researchers went back, only 5 of these episodes, 5 of the 18, actually were classified as pneumonia. So what the researchers were saying is that there was an overtreatment according to sputum results or from culture results that were taken from the stoma or the trachea. So they concluded that patients with chronic trachs have low risk of developing pneumonia despite significant colonization of stoma and trachea. So this is something to keep in mind going forward in treating your patients. So take home points, MDRO infections are a major concern in the nursing home population because they are at risk of developing severe infections from these organisms. It's important to understand the difference between colonization and active infection in order to determine when we need to initiate antibiotics. Clinical criteria provide guidelines to determine when we start antibiotics. It's important to utilize them. It's important that we are all using the SBAR to help guide assessment, aid communication, and then determine best action when we communicate with our provider. And now we'll see some questions. I think there are some.
Okay. I'm going to stop sharing my screen. Now I can see you all again. At this time, we will start our live Q&A with Dr. Storm, who is here. If you have a question or comment, please share them with us using the chat or the Q&A tools in your Zoom menu. You can also raise your hand to request to be unmuted to ask your question out loud. And for anyone wanting the presentation slides, I just dropped a link in the chat that you can use to download it. While we're waiting, I'd again like to invite everyone to next week's webinar. Joni Price of West Virginia Project First Line will join us to talk about the program's state and national resources for infection prevention. And we also invite you to bring your questions to our virtual live chats, which are each Tuesday and Thursday at noon. One of our quality improvement specialists will be there to answer your questions on topics like quality improvement initiatives, infection control, or MDS coding. You can find a link to join those live chats in our webinar email reminders, as well as our Friday newsletter, The Last Minute Lowdown. And if you're not on our mailing list for the Last Minute Lowdown, but you would like to be, you can email me at ccaudell@qualityinsights.org to be added to our mailing list. And I will drop my information and Dr. Storm's information in the chat shortly too. Okay, so it looks like we have a question. If there is a resident stated to have been positive for CRE in urine, not being treated with antibiotic at this time, how long to keep on isolation?
So this resident is not, I'm hoping that from the question that the resident is not doesn't have any signs of infection because they're not being treated with an antibiotic. So it sounds like that this resident is colonized in their urine. So there is no indication to isolate this resident because they have a colonization. I will say because they are colonized with an MDRO, this resident would qualify for enhanced barrier precautions, which is when you do direct care activities such as toileting, changing of clothes, personal care like shaving, washing, changing of this resident's linen in their room, then staff would wear gown and gloves to perform these activities. And then they would remove the gown and gloves and perform hand hygiene after they perform the activity when they leave the room. The resident should not be isolated in their room because they're colonized with an MDRO, and you should not utilize enhanced barrier precautions when they are outside of the rooms eating, all of those kinds of things. CDC does have signs on their website. If you can Google the CDC enhanced barrier precaution website. That's perfect. I see you say you have currently a patient on enhanced barrier precaution. That's perfect. That's what you should be doing. The resident should not be isolated. You can't just keep the resident in the room. The resident should be able to go ahead and have activities. The idea is that the urine is contained in a brief, that we don't have it's not like it's a draining wound, that is, in other places in the facility. So enhanced barrier precautions is perfect in this case.
Thank you for your question. If anybody else has a question, please submit it at this time. We'll probably just take another minute or two to make sure that everybody who has a question has a chance to submit it. And of course, as I said before, if you use the raise your hand tool, we'll know that you would like to ask your question out loud and we can unmute you. While we're waiting, I'm going to drop the flyer in the chat again that we had from earlier. For anyone who was not here at the beginning of the webinar, we have a special presentation coming up in a couple weeks at the same time. It'll be Wednesday, April 12th. Dr. Storm will be here to talk about advanced drug events. Did I say that right? Adverse drug events.
Adverse drug events. Let's say ADE.
Yeah. Okay, I think that's it for questions today. Let me get a couple notes here to wrap us up. Before we sign off, I'd like to ask everyone here to please answer a short evaluation of today's webinar. The evaluation is anonymous and will show as a pop-up as soon as the webinar ends. And if you have a couple minutes to fill that out, we would appreciate it. I'd like to thank all of you for joining us today. And Dr. Storm, thank you for joining us again. We hope to see you all back here.
I'm sorry, there's one question.
The
question came up.
Oh, you're right. It popped into the Q&A. Okay. It says, any ideas on getting our providers on board with appropriate antibiotic prescribing?
I would share with them all the criteria that were shared in that PowerPoint. Providers love criteria. I really feel like as a clinician, when you're making decisions all day long about, little things and big things, you get decision overload. So if you show the provider, this is the clinical criteria, can we sit down together? Can we talk about if this resident meets clinical criteria and then walk through it with them? And then if they decide to initiate antibiotics or decide not to initiate antibiotics, they can put that in their note, why they decided and why they, didn't decide. And, that looks wonderful for survey when you have CMS, when you have the survey agency coming in and looking at your antibiotic prescribing. If you have a provider who's utilizing clinical criteria to make an antibiotic decision, that looks fantastic. You're doing everything that you should be doing for antibiotic stewardship. So I would encourage you to share that clinical criteria with the providers.
Thank you for that question. And I put the presentation slides back in the chat again, if anybody missed that. She said, thank you. And I think that's it. Do you want to take another minute in case anybody else has a last moment question?
My email is in that presentation. If you'd like to reach out with any other questions, I know some of you have done that after previous presentations. Go ahead and do that.
Sure. Dr. Storm's email is jstorm@qualityinsights.org. All right, I will wrap us up. Dr. Storm, thank you for joining us again. And I'd like to thank all of you for joining us again today.